I'm Dr. Swaleha Mujawar. I'm assistant professor at Subharti Medical College. And today we are going to discuss the role of long-acting injections in schizophrenia management. And specifically, our focus for today is paliperidone injection. But before that, let's just get a context into the whole situation, what is happening. So we all know schizophrenia is a disease in which there is distortion of thinking and perception. It is a disorder which causes considerable disability. So we don't have any doubt that it's a very major illness, and it's a very varied illness also. So it can present with anything from positive symptoms like delusions, hallucinations, negative symptoms like alogia, evolution. There are a lot of cognitive defects also. Sometimes mood symptoms might be found. There's a lot of comorbid substance use also, and all these things lead to work and interpersonal problems. Looking at the natural history of schizophrenia, it starts with a pre-morbid stage. Then we go to prodrome, that is just before the illness or the symptoms start. Then there is the actual onset of symptoms, which usually has positive, negative, and cognitive symptoms. After the onset or the acute phase, then comes the chronic and residual phase. So what we want to tell you is that it's a very long acting illness. It goes on for years at a time. And because of this, our treatment is also divided accordingly. So our treatment is acute phase, stabilization phase, and then maintenance phase. So in acute phase, our focus is the psychotic symptoms which are very severe, which are causing considerable problems. So delusions, hallucinations, suspiciousness, all these things, and it usually lasts for 4 to 8 weeks. Then comes your stabilization phase. So the acute symptoms have gone down, but there are still symptoms remaining. So we try to stabilize or bring down the symptoms as much as possible. This phase again lasts for approximately 6 months. Then is your maintenance phase. So in maintenance phase, our main aim is to prevent further psychotic episodes. So there are no psychotic symptoms or there are no schizophrenic symptoms, but we want that the symptoms should not flare up or the symptoms should not come up again. So this is our aim in maintenance phase. So treatment of schizophrenia again can be divided into pharmacological, non-pharmacological or combined. In pharmacological, we have antipsychotics. In non-pharmacological, we have CBT, attention training techniques, etc. In oral antipsychotics, we again divided into two parts, the first generation antipsychotics and the second generation. So first generation are your chlorpromazine, haloperidol, trifluperazine. Second generation are risperidone, olanzapine, quetiapine, aripiprazole. So these are the list of antipsychotics which we usually use. And whenever we give oral antipsychotics, there are some limitations. Like except for clozapine, all the other medications have similar efficacy. So the effectiveness is same, but their side effects are different. We'll be looking what these are in the further slides. But whenever we increase the dose, it is seen that the adverse effects also keep on increasing. And because of these adverse effects, there is non-adherence. Non-adherence means the patient just leaves the treatment. And that is where our oral antipsychotics come into the picture. So non-adherence to antipsychotics is frequently observed, and adherence can be improved by using long-acting injections. So what are the long-acting injectables that we have? What are the options? From a historical perspective, 1960s was when fluphenazine was started, and then fluphenazine deconate was given. Then came haloperidol, and then after that the second generation antipsychotics were also used as long-acting like risperidone, paliperidone, olanzapine. So a difference between the first generation and second generation antipsychotics is the first generation are oily preparations. So the injections are usually very painful to give and very difficult also. And in second generation, they are microsphere crystals, so they are water-based injections. So the pain is less, the discomfort to the patient is less. Now, first generation versus second generation long acting. So, as expected with oral medications, the same is with long acting also. So, acute EPS, that is extrapyramidal symptom, tardive dyskinesia, hyperprolactinemia, all this is more with first generation, and all this is less or lesser comparatively with second generation. But again, with second generation, we see that there is a risk of weight gain. They are a bit more expensive also. So first generation have the advantages of having no metabolic side effects, and they are significantly cheaper when compared to second generation. Now coming to the focus of our today's lecture, that is paliperidone injection. So what is paliperidone? Paliperidone palmitate, it's a 1 monthly injection. It was approved by the FDA in 2011. It is basically paliperidone, which is a metabolite, an active metabolite of risperidone. It's a water-based formulation, just like any second generation antipsychotic. The mechanism of action, again, like all second generation antipsychotics, it works on D2 receptors, 5-HT2A receptors. Also, it acts on alpha 2 receptor. So, it has an added advantage that it works for mood symptoms also. And how does the drug release occur? We give the injection deep intramuscular. So what we are doing is we are putting the molecule inside the muscles. Once it goes and sits inside the muscles, it is released slowly over a period of 1 month. So this is what happens when you give the injection by deep IM. Now, whatever we do as doctors are all evidence based. So, what are the evidences that we have? Let's look at a few studies. The first study is a RCT. So, it compared paliperidone with placebo. So, they used adult patients with schizophrenia, and PANASYS was applied, and then the patients were randomly divided into 4 groups: placebo, then paliperidone 25 mg, 50 mg, and 100 mg. And then at the end of 13-week period, they measured PANASYS, CGI, and other treatment markers. So what was seen was that, so this is the placebo, as you can see, and these are the paliperidone, the darker ones. So comparatively, a significant difference in all reduction of all the scores. So especially PANASYS scores were significantly lower as compared to placebo. So it was definitely acting on positive symptoms also and negative symptoms. The second study was if you want to switch from risperidone to paliperidone. A lot of times we do have this situation in the clinics. So what this study did was it compared 319 patients, and what was found was that when they switched from a risperidone long acting to paliperidone, there was a lower risk of schizophrenia related hospitalization, longer duration of therapy compared to risperidone LA and an oral agent also. So yes, it was superior to risperidone LA. Now, how does it fare with our oral antipsychotics? So again, this study was done. In this study, 226 patients were given paliperidone, 218 patients were given oral antipsychotics. And again, what was found was that compared to any like conventional, that is first generation, atypical is second generation, or paliperidone, risperidone, compared to any oral antipsychotic, the once monthly paliperidone was effective, and definitely you can see by the graph also there is a significant difference between all of them. Now coming to the metabolic parameters, because we are giving second generation antipsychotics, we will be looking upon the weight gain or the metabolic profile, what are the side effects that can happen. So again, this was a RCT done for 13 weeks. They have taken 51 adult patients, so lesser compared to all other studies. But again, they measured the PAN-SS score, and they saw that the PAN-SS score decrease was again comparable. There was no significant difference, but the weight gain in paliperidone group was 3.64 kg less than the olanzapine group. So compared to olanzapine, the weight gain was lesser, and improvement was similar, but what we were focusing on was the metabolic side effects. Now coming to prescribing information. So when you want to start or give a patient with paliperidone, what should you do? It is given in acute and maintenance phase of schizophrenia. So schizophrenia is the indication currently. We start with an initiation dose and then a maintenance dose. So initiation doses are two in number. We start with 150 mg on day 1, and then we give 100 mg on day 8. This is the initiation dose. After initiation comes your maintenance. So maintenance starts from your second. So whatever day you have given the second injection, that day will be counted, and every month you have to give. For example, if you have given an injection today on 23rd, so every month 23rd the patient will be scheduled for an injection. Also remember that the first two doses are given in the deltoid muscle, because the blood levels are rapidly formed for that. So that's why deltoid is the preferred site for initiation. After initiation, you can give in deltoid or gluteal, whatever the patient or you are comfortable with. But the initiation is always in the deltoid, and the initiation is always 150 mg and 100 mg. Thereafter, again depending upon the patient response and the symptoms, you can give anything from 25 to 150 mg, so that you can decide accordingly. Now, equivalent doses are very, very important. So, from a remembering point of view, just remember risperidone, paliperidone is just the double of risperidone, especially for PG students who want to rote learn or remember, just remember it's twice. So, if you can just remember one table, you will be able to remember the rest. So, if the patient is on 2 mg risperidone or paliperidone 4 mg, you can give risperidone consta, that is the long-acting risperidone 25 mg, and paliperidone 50 mg. And thereafter, you can increase. So, if the patient is able to tolerate 4 mg of risperidone, you can easily give 100 mg paliperidone. Now, the special population. This drug is known to be excreted by the kidneys, and geriatric or elderly patients, we know that they have decreased renal function. So be very, very careful if you want to give it in geriatric patients. Second, it is safe to give in hepatic impairment. So definitely patients with hepatic impairment, mild to moderate, you can safely give. But yes, again, if there is severe hepatic impairment, just be very careful. Renal impairment, we have seen, not recommended for moderate or severe renal impairment. Mild renal impairment, dose reduction is advised, but I would advise just avoid as much as possible. Pregnancy and lactation. Extrapyramidal and withdrawal symptoms are seen in the neonate, especially if it is given in the third trimester of pregnancy. So again, be very, very careful when you're giving in pregnancy and lactation patients. Now, adverse reaction and contraindications, they're the same as that for risperidone or paliperidone. So the adverse reactions found in clinical trials were insomnia, headache, anxiety, sometimes upper respiratory tract infection. Injection site reaction can also occur, so be very, very careful whenever you're giving a deep IM injection. Just make sure that there are aseptic precautions. The patient doesn't have a local infection or inflammation wherever you're giving the injection. Then again, weight gain, somnolence, nausea, all these are seen with oral medication also. Contraindication, the only contraindication is hypersensitivity to either paliperidone or risperidone. If the patient has had anaphylactic reactions or angioedema, do not give the injection. Now coming to the key highlights. So the take-home message or the key highlights are that paliperidone long-acting in schizophrenia, it causes significant improvement when they were compared with placebo, significant improvement when compared to oral antipsychotics. Also when it was switched from other antipsychotics, again significant improvement was seen, and long-term paliperidone treatment was significantly more effective than oral antipsychotics. And again, metabolic profile was favorable, especially compared to olanzapine. So with that, I would like to end my presentation. Thank you so much for listening, and I would like to open this topic for discussion.